Okay, let's begin to talk about the anatomy and physiology of the auditory system. In this lecture, we're going to have a brief review of the anatomy of the auditory system. And then we'll talk about the external ear anatomy and physiology, following by the physical examination of the external ear and the tympanic membrane. The ears and vertebrae kind of show have a common biology. There's some variations in the structures as we go up in the strata of within the vertebrae, and there's variations within species. But there is an astonishing similarity, and you can see a hierarchy in terms of evolutionary adaptation. For instance, the fishes and the amphibians that live in water lack many of the structures that we call as a middle ear. And while in mammals, there is kind of similarity between in the external ear and the middle ear and the inner ear structures. The ear not only acts as the receiver of the sound, the auditory system also includes a vestibular system, which is important for our sense of balance and our body position. In terms of similarity, in vertebrae, the ears are placed symmetrically on both sides of the head, and that plays an important role in terms of localization, our ability to localize the sound source kind of in a three-dimensional space around us. It also plays a role in our balance, in our vestibular system, something that we're going to be talking about down the road. So here is a picture of the a common schematic representation of the auditory system. Specifically, we are looking at the external, the peripheral auditory system, I should say peripheral auditory system, which includes the external ear, the pinna, the external auditory canal or meatus, ending at the tympanic membrane, which leads to the middle ear structures, which include those smallest bones in the human body, the ossicles, and the smallest of those ossicles, a stapes, is fit into the oval window, which is the beginning of the inner ear. So the inner ear includes the sensory apparatus for the auditory system. It's where the hair cells are located within the cochlea, which are the final transducers for the sound stimulus, and it translates that into electrical impulses that are going to be carried by the auditory nerve, or the eighth cranial nerve, towards the brain. The inner ear also has the vestibular system, which would be the utricle and saccule over here, and over which sit the semicircular canals, the three semicircular canals. And when a layperson thinks about the ear, they often think about just the pinna, the auricle, although much of the processing happens beyond that, and the pinna, the auricle, in humans play a very little role. Some of the external ear structures are absent, as I said, in other animals, and actually in some animals they play a larger role than they do in humans. Much of the muscles in our external ear are what we call as vestigial. They don't have an active purpose, while in some animals actually those muscles can contract, changing the shape of the pinna or changing the orientation of the pinna. You probably might have noticed your dog, or you can clearly see some cats doing that. However, the shape and the size of the pinna actually plays a role, a small role, and we'll be talking about that in a bit. One of the role it plays is that it's what limits our frequency range, especially for the lower frequencies. So when we say that the humans hear from 20 hertz to 20,000 hertz, the reason why we begin hearing at 20 hertz is because of the size of the pinna. In some mammals, let's say the elephant, we talked about how they can hear at very low frequencies, and kind of is because of the shape, the size of their pinna, which is much wider. So the whole auditory system can be divided into this peripheral system and the central system. We have a fair understanding of what's going on in the peripheral system. In other words, how sound is transduced or converted from its physical form into a form that the nervous system, the eighth cranial nerve, can understand, namely in electrical form, electrical pulses. As I said, it's our understanding of what's happening in the inner ear and the eighth cranial nerve that's made us possible to make successful implants like the cochlear implant. And recently, with advances in technology, based on our understanding of the physiology of the inner ear, the cochlear implants seem to be are quite successful in restoring the hearing to many individuals who have a significant hearing loss. We are only beginning to understand what's happening beyond the auditory nerve. But we do understand that there's a large amount of processing happening in those pathways that even lead to the brain. So there are certain parts of the brain that are responsible for the final interpretation of a stimulus like speech. But even in the structures along the pathway, along in the brainstem and in the subcortical structure, there seems to be a lot of processing happening, especially in terms of teasing out language from speech and our ability to listen to speech even when it's distorted or when there's a background noise. So all that falls within the domain of central auditory processing, and it relates to some conditions such as the central auditory processing disorders that we might talk about down the semester. Eventually, we are going to be understanding what's happening within the auditory central auditory system, and that might result in better implants, such as brainstem implants, and for those small population of individuals for who a cochlear implant may not work because the damage is beyond the auditory nerve. One needs to appreciate the complexity of the auditory system, and the size of these components of the auditory system is a good reflection of that. So we begin with the external ear, which is probably, for most of us, in adult ears, it's a couple of inches. But the real physiology happens at those really small structures within the inner ear. So we are moving from macro mechanics to micromechanics. So the structures in the middle ear are probably a couple of millimeters in size, with the stapes being the smallest bone in the human body, as you can see over here, lying over a penny. But structures within the inner ear are, of course, much more smaller in dimensions. In fact, they are in the dimensions of micrometers, like the hair cells. They are only about 10 micrometers, micro meaning 1/1,000,000th of a meter. But the real transducer is on the top of those hair cells that lie within the inner ear, namely the stereocilia. The stereocilia are in the dimensions of nanometers, or 10 to the power of -9 meters. And so we're talking about real small structures, and hence the time it took for us to come up with technology to actually examine these structures and understand what they do. Here's another illustration that shows you the external ear and how the information is actually transmitted from the auditory nerve, from the inner ear, and it proceeds superior or upwards to the part of the brain, namely the temporal lobe, where the final interpretation of the audio message happens. Okay, let's begin with the external ear. As I said, it plays only a small role in terms of hearing in the humans, and actually plays no role at all in terms of the balance. It's also known as an auricle, and as I mentioned earlier, it's the size of the auricle that actually limits us hearing at very low frequencies. Its main function seems to be collecting sounds from the environment and kind of funneling them down the ear canal to the middle ear. It's got three main parts: the auricle or the pinna, the most exterior part, and the external auditory canal, which leads to the tympanic membrane at the end. The pinna is actually made up of a cartilage, which is an elastic connective tissue, and it's covered by the skin. The lobule at the downward tip of the pinna is the part that's not covered by cartilage, and it's the most soft and pliable part of the cartilage of the external ear. As I said, some of the muscles surrounding the external ear are active in some animals, hence their ability to kind of move the external ear in different directions, kind of focusing in towards the direction of the sound source, helping them hear those sounds better. But in humans, those are vestigial, so we can't move our pinna. So if you see any people who are moving the pinna, they're actually moving their neck muscles and to twitch their pinna. There are some important landmarks in the pinna that we might need to acquaint ourselves with. So we've got the tragus over here. The tragus is also, it's actually a Greek word for goat's beard. That's because for many individuals we have some hair in this tragus part. The tragus is also a very efficient way of depressing the tragus is an efficient way of cutting off sounds that we often do. And apparently it's even more efficient than any of the best of the earplugs that we have. So if we were to depress that and shutting down the ear canal. Some amphibians have the ability to voluntarily close the tragus, kind of cutting off water entering into the external auditory canal. Opposite to the tragus, diagonally opposite to the tragus, is your antitragus. It's another landmark. Then, of course, we talked about the earlobe or the lobule at the very bottom. Kind of the outer periphery of your external ear is your helix, and following the same curve is your antihelix running inwards. The kind of concave cavity in the very center is your concha, and it can be divided into the cymba concha and the cavum concha. Good. And the concha is what leads to the external auditory canal, or the opening of the external auditory canal over here. Here's another kind of more real picture of the external ear, showing you those different landmarks. So here we have the external auditory meatus of the ear canal. That's kind of covered by this tragus. The auricle is attached by ligaments and muscles to the skull. So it's actually, it can be severed in some extreme cases. We do see individuals where the external auditory canal is severed. Of course, cosmetically that might be unappealing, but from an auditory standpoint of view, it doesn't seem to result in a significant hearing loss. The auricle is supplied by the posterior auricular artery, which is a branch of the external carotid artery. And the auricle in general receives a kind of intense blood supply. Reason why when it's hurt, if somebody um, kind of hits your ear, it inflames um, quite rapidly, and it can bulge. It's also the reason why you feel cold more in the pinna. The ears get cold. When it gets cold, it becomes red in color because of that intense blood supply. As I mentioned earlier, the pinna serves to direct sounds to the auditory canal, and it's more efficient in delivering higher frequency sounds and lower frequency sounds. And it plays a role in localizing sounds. So as I said, some birds can actually twitch their ears, and you probably would notice that dramatically in owls, where they can change the direction of the pinna, and that improves their ability to localize a sound. Okay. The pinna leads to the external auditory canal. It's about an inch elliptical tube that begins at the concha, and it kind of extends inwards in a slightly upward and forward direction. So it's kind of curved, especially in adults. In children, it's more straight, and it's around age of 3 years when the jaw drops and the face becomes kind of elliptical, is when you get that downward shaped and pinna, an external auditory canal. Pardon me. Okay, it's a shape of the external auditory canal that kind of necessitates us orienting the external canal upwards and backwards when we're trying to examine the tympanic membrane using an otoscope. So here's a schematic illustration again of the external ear. So you can see there's actually two bends in the external auditory canal, and the curvaceous nature of the external auditory canal actually serves a purpose. We'll talk about it in just a few slides down. The external auditory canal has two parts. The outer part is cartilaginous, while the inner part is within the bony opening in the skull. It's a cartilaginous part of the pinna that actually has the sebaceous glands that results in making earwax, what we call a ceramen. It's also the part that has hair follicles. And the hair follicles and the wax actually serve a purpose because they make an oily secretion that helps in trapping dust and insects, which actually had a purpose for our ancestors who lived in forest. Now it's more of an obstacle for audiologists who try to view the tympanic membrane and do procedures like take an ear impression for moles and for hearing aids. So the inner part of the external auditory canal passes through the tympanic portion of the temporal bone that encases the middle ear and the inner ear. There's actually a cranial nerve that traverses at the floor of the external auditory canal, namely the cranial nerve 10, the vagus nerve. And it's the reason why when we use a Q-tip and try to stimulate the ear canal, it might result in a sneezing or a coughing reflex, known as the Arnold's reflex. The tympanic membrane is located at the very end of the external auditory canal. So let's talk about the small role that the external ear plays within the auditory system. So let's divide that into non-acoustic and acoustic functions. In the non-acoustic function, the shape of the canal actually protects the tympanic membrane from trauma. So being it curvaceous, being it curved, a straight object would not directly puncture the tympanic membrane. It also serves a purpose by keeping the tympanic membrane at a constant temperature and humidity. So and it's almost like a cave, and we know that caves are pretty good in maintaining a constant temperature and humidity. The reason why in earlier days people were storing food and grains in caverns or caves. And apparently that was a story for the Bristol caverns that we have in our neighborhood, where people were saving their produce in those caves. The canal has those hair follicles that actually serves a purpose in removing periodically the ear wax at the cerumen from the external artery canal. The reason why you'd see, like in children, you can actually see the wax kind of collected at the periphery because we have a natural way of kind of pushing out the wax and the dust. And as we grow older, the function of this hair follicles, what we call a cilia, um, becomes poorer. It's the reason why in older individuals wax seems to accumulate a lot in the ear canal, and we need to have some external help like ear drops to periodically clean the ear canal. One thing you need to remember is that those wax and the hair follicles are in the external part of the ear canal. So sometimes with all good intention, when we use those Q-tips, we might plunge the ear wax further down the ear canal, a part of the ear canal which doesn't have this normal way of removing the ear wax, and so you might end up creating a wall of ear wax that might result in complications later. Acoustically, as I said, the external ear, because of its shape and size, kind of determines what frequencies we best hear through. It serves to filter the lower frequencies, and it kind of gives a boost for those mid frequencies, around 2000 to 1000 hertz. And especially with the peak resonance for most ears at around 3400 hertz or 3400 hertz. Can almost pump up the amplitude of those frequencies by 5 to 20 dB. So what you're seeing over here is what we call as a transfer function. So we're looking at how amplitude is amplified, okay, across frequency. So just with the ear canal and the pinna, just because of their size and shape, they have what we have peak resonances around those mid frequencies, and that can almost amount to 20 dB amplitude increase at those frequencies. So if you were to give like a flat noise, you're going to see by the time it reaches the tympanic membrane, there's an improvement or there's an increase in amplitude of about 20 dB. Okay. And larger the collecting surface, slightly better amplitude of those frequencies. The reason why those ear horns were working back in those days before hearing aids to improve hearing. The pinna also plays a role in spatial hearing or localization of sound sources. Each individual's pinna, because of the small kind of curves in the pinna, it results in modifying the acoustics of the sound before it reaches the ear canal. So specifically, it reduces the sound coming from the back of the ear, and then for sounds that are what we call a 90 degrees azimuth. In other words, that they're facing directly the ear. So we have learned to recognize which direction the sound source is by comparing the amplitude of sounds coming from the back and the front, and that kind of improves our hearing if you're facing a speaker. Okay, and that's what we call as a shadow effect, kind of blocking sounds coming from the back and improving the sounds coming that sound sources that are facing us. So that brings us to the tympanic membrane. So the tympanic membrane is kind of the boundary between our external and the middle ear. It's a very thin membrane. It's only about 0.1 to 0.4 millimeter, hence it's very delicate. Um, and the way it's attached to the ossicles, it results in making it a concave shape. In other words, it's curved more inwards. In a healthy tympanic membrane, it's semi-transparent, so you should be able to see some of the ossicles that lie behind it. And it's kind of oval shaped, and it's directed not perpendicular to the ear canal, but kind of slanted and almost about 55 degrees to the floor of the ear canal. And apparently that has a protective function too, because we know that things that are slanted are more stable, and so that gives kind of a little bit of stability and protection to the ear canal. So here you're seeing actually a CT scan of the head, where you can see the curves of the ear canal leading to the tympanic membrane. What you're seeing over here at the back is those air-filled mastoid hair cells, and you can. Another important point is that the middle ear is in very close proximity to the brain structures, and that kind of makes it clinically relevant. If you have a long-standing infection, there's a chance that the bone can erode and result in affecting the brain, result in conditions like meningitis. Kind of places importance about those long-standing ear infections that result in actually more severe complications, such as a brain infection. The tympanic membrane has 3 layers. The outer layer, outer towards the external ear layer, is cutaneous. It's covered by the same epidermis as the skin of the external auditory canal. The middle layer is what gives kind of stiffness and structure to the tympanic membrane. It's made up of a tough fibrous connective tissue, and it's what results in the elasticity of the tympanic membrane. The third layer, the innermost layer, is it's continuous with the membranes of the middle ear. It's a mucous membrane and it's moist. The tympanic membrane, as I said, even though it's very thin, it's a very efficient vibrating membrane. So when we talked about the decibel, we talked about how the human auditory system is very sensitive to pressure deflections, and we can hear sounds as low as 20 micropascals. So put that in relation to 100 kilopascals, which is our atmospheric pressure. So we're talking about 20 micropascals, very small deflections. But the tympanic membrane is so efficient that it can capture those pressure deflections, and we interpret that as sound. The entire area of the tympanic membrane is kind of intensely supplied with blood arteries, and especially specifically by the internal maxillary artery. And again, when it's irritated or if there's an infection, that's the reason why the tympanic membrane might seem bloody red, because of this intense blood supply. For the most part, the circumference of the tympanic membrane is kind of held in place by this fibrocartilaginous ring we call as the annulus. This ring is not complete. The top part of the tympanic membrane does not have this ring, and it's in this top part that we have this part of the tympanic membrane that we call as a pars flaccida. It's flaccid and thin because it lacks the middle fibrous layer, and but the remaining part of the tympanic membrane have, of course, the 3 layers of the tympanic membrane, and they are known as a pars tensa because they have a elasticity that they're tensed. So here's another image of the tympanic membrane showing you kind of the pars tensa with that fibrous tissue in it. And the top part is where the annulus is incomplete, and we call that as a pars flaccida. So these are illustrations of healthy tympanic membranes. We've got the right one here and the left one here. And we know it's the right one because one of the landmarks is this cone of light. And this cone of light is but the reflection of the otoscope light. But the way the tympanic membrane is kind of arched and curved, it results in creating this reflex, this light reflex, which is at about 5 o'clock if you're looking at the right tympanic membrane, and is at 7 o'clock if you're looking at the left tympanic membrane. An easy way of remembering that would be for the right ear and the left ear, cone of light kind of points towards nose. So as I said, the remaining part, of the majority of the tympanic membrane is the flexible tensed part, and it's known as a pars tensa. The tip of the malleus, the first of the ossicles and the largest of the ossicles, is attached to the center of the tympanic membrane at a point that we call as an umbo. This is a point which is maximally retracted inwards, and it's what results in that concave shape of the tympanic membrane. Here's a schematic illustration of the tympanic membrane with some important landmarks. So we talked about the cone of light, and we can say this is the right ear because it's at 5 o'clock. You got the annulus around it, and in a healthy tympanic membrane, we should be able to see at least two of those ossicles, reflections of two of the ossicles. The manubrium of the malleus. Manubrium is one part of the long leg of the malleus. And if you were to look just behind that, you might see a reflection of the umbo. The incus. And the umbo refers to the point where the malleus is attached to the tympanic membrane in the middle ear, and that's what results in its curve. Here in this illustration again, you're seeing the curved tympanic membrane attached at the point of umbo, and followed by the ossicles, the malleus, the incus, and the smallest of the bones, the stapes, which connects it to the inner ear. So you're seeing a chain of ossicles over here that actually take the mechanical vibrations of the tympanic membrane and takes it towards the inner ear. Here is an illustration of a tympanic membrane with a PE tube, or a pressure equalization tube. And you can see these tubes are really small, that help in some children and some adults in controlling their ear infections. We talked about the cone of light, how it's a night reflex, and you see that in the inferior anterior part of the tympanic membrane, so the lower and front portion of the tympanic membrane. One of the first procedures we do in an audiological assessment is this physical examination of the ear. And we do that with an otoscope. And in many cases, this might be the only procedure we do. So these are patients who have, if we see any evidence of an active ear infection, or obviously there is some kind of pathology inside the ear, we're going to send them as early as possible for medical attention. And we wouldn't be able to do any other procedure. Again, as an audiologist, we would not make a medical diagnosis, even if we do an otoscopic examination. Would be the ENT or their family practitioner who makes a diagnosis of what the condition is and of course provide prescriptions for medicines or recommend a surgical procedure. However, otoscopy can give us some important information, and as I said, it's pretty much the first procedure we do, probably after case history. Okay. In otoscopy, we are trying to directly visualize the external auditory canal and look at the tympanic membrane. In some cases, our otoscopy might also give us how the eustachian tube is, and how the middle ear status is. When we're doing otoscopy, we briefly describe the procedure to the patient, reassure him that the examination is painless and it'll be quick to perform. We tell them that we're going to be pulling their ear upwards and backwards to kind of facilitate us looking at the ear canal and the tympanic membrane. And while we're doing this procedure, we always try to get feedback from the patient in terms of whether this procedure is comfortable, and if they experience any pain, we want to make a note of that and appropriately make recommendations. I'm going to be attaching a video recording of an otoscopic examination soon. But when we're doing our otoscopic examination, we use speculums, and mostly these speculums are disposable speculums. We try to find the largest speculum that can fit into this person's ear canal comfortably. There's typically two sizes of speculums, one for pediatrics and one for adults. We orient the patient's head, so it's kind of like our head level, so in that way we get a better view of the ear canal. And we pull for adults, we pull the ear up and backwards. Again, the intention is to straighten, it's the first of the curves of the ear canal, and we can get a better view of the tympanic membrane. As I mentioned earlier, for children, we might have to adapt the procedure by pulling the ear downwards and forwards because their ear canals are shaped differently. So what we're looking at is the overall size, the shape, and the color of the ear canal. The ear canal should be skin colored, and we do expect to see some hair follicles and wax. But if the ear wax or cerumen it seems to be excessive, we might want to make a recommendation for a lavage, where they try to remove the ear wax prior to continuing with the patient. What we consider abnormal is if, when we're doing the procedure, the patient complains of discomfort when you're pulling the ear, the pinna. And when we look at the ear canal, if we see any inflammation, if you see any foreign body, or if you see any blood or pus, that would be considered abnormal. After examining the ear canal, we look at the tympanic membrane. Healthy, normal tympanic membrane should be pearly white, slightly gray, and you should be able to see the important landmarks, including the cone of light, the shadow of the malleus, and kind of the annulus, the outer ring of the tympanic membrane. It would be considered abnormal if you're seeing a dull or an absent light reflex. If you see the tympanic membrane is inflamed and red, or if it's bulging, that would indicate there's an infection in the tympanic membrane and/or in the middle ear. An infection of the tympanic membrane is what we call as myringitis, and so if it's acutely red, we call it as an acute myringitis. In some cases, you might see some fluid or air bubbles behind the eardrum. That might be an indication of an ear infection or of the middle ear. Could be a condition that we call as otitis media. In some cases, you might see scar tissue on the tympanic membrane. So that kind of will tell us there's a history of perforation that's probably healed. Um, and you might want to probe into that, see if they were aware of that, or if the perforation and the healing is because of placement of tubes in an earlier age. Um, and if you're looking at a child, you might actually see the PE tubes if they have had that procedure. Um, Usually they are white, or actually nowadays they come in more fluorescent colors also, as pink or green. And as I mentioned earlier, you might see excessive wax in the ear canal also. Or you might see cases where there's a perforation in the tympanic membrane. And if this perforation is, and you don't see any indication of an active ear infection, you can kind of confirm whether you're looking at a perforation by other procedures